everyone. It's my pleasure to welcome Dr. Harsimran Walia for today's talk in the STEP webinar on ABG interpretation. Dr. Harsimran is Associate Professor, Homi Baba Cancer Hospital, Chandigarh. Welcome, Dr. Harsimran.
Thank you. Thank you so much, Dr. Nitin. Thank you for having me.
Yeah.
So today's discussion, if I can start, is on ABG interpretation. So ABG forms a very important component both in the emergency department as well as in the ICU as well as in OT. So most of the times ABG interpretation becomes very important. So let's start. So to outline my entire presentation, first I would like to tell you about the components of ABG. Second, very important from nursing point of view are the errors that are normally performed while taking an ABG sample. Now, once the sample has been taken, how you analyze an ABG. So there are 7 golden steps how to analyze an ABG. Then we also can see an ion gap that becomes very important in emergency, especially in patients with poisoning or in patients with which comes in sepsis. So last is differentials and examples. So examples I will take at the last for specific acid-base disorders. So we are not going into mixed disorders, but basics of ABG I will try to cover in this presentation. So first and foremost, components of ABG. So once you have an ABG in your hand, what all you see? So there are a list of almost 15-20 parameters that we normally see. We don't have to be hassled seeing all these values. The paramount important values are just 4 and 5. So most important will be pH. pH is the measurement of acidity or alkalinity based on the hydrogen ion. So the normal value of pH, very important till 2 decibel. It is 7.35 to 7.45. So you should not say it is 7.3 to 7.4. So up till 2 decibel, the value needs to be told. So it is 7.35 to 7.45. The next important thing is to see the oxygenation. So we also see the value of P small aO2. PaO2 is P arterial oxygen, partial pressure of arterial oxygenation. The partial pressure oxygen that is dissolved in the blood. So normal value again, very important, is 80 to 100 mm mercury. Then we also see PCO2, normal value 35 to 45 mm mercury. Bicarbonate, normal value 22 to 26 or 22 to 28 millimoles per liter. And we also see the saturation. So we all know the normal saturation is above 95%. So these are the values that we look at, and we should also know the normal. So to tell abnormal, we should know what is the normal value. So if we know that pH is 7.34, that means that patient is acidic or there is acidemia present in the body. In the same way, if the patient's pH is 7.46, patient is alkalemic or alkalemia is there in the body. Now, if we see the pH, PaO2 and PaCO2 along with lactates and electrolytes are the measured values in the ABG that we normally measure. But one variable that can be measured or calculated, that is the bicarbonate value. So the other thing also, so it does tell us about the electrolytes also. So rather than waiting for 1 hour for the electrolytes to come from the laboratory, so this ABG that can be taken within 2 minutes and analyzed. So this saves a lot of time in emergency department. So the values are reliable if ABG is calibrated. So yes, electrolytes are also told by ABG. Sodium value again normal is very important. 135 to 145 millimoles per liter. Potassium value of 3.5 to 5.5 millimoles per liter. Calcium, what ABG tells us is ionized calcium. Value is 1.13 to 1.32. Chloride 98 to 106 millimoles per liter. And again, I told you very important is the anion gap. So anion gap is 12 plus minus 2 millimoles per liter. It becomes very important in toxicology, also in septic patients. Now moving on. Why we need to order an ABG? Why an ABG should be done? So as I told you, we already get to know almost 15 to 20 values. So the important thing is it aids in establishing diagnosis. Once the patient comes to us, we need to know what is the underlying diagnosis. So if we know the diagnosis, then we can guide our treatment plan accordingly. And if the patient is on ventilator, the PF ratios, the oxygenation status is also told by the ABG. So yes, it aids in ventilator management as well. So it improves the acid-base management. That is the crux of it. So ABG name is arterial blood gas, and it does tell us about the acid and base management and also the electrolyte status when the patient is very, very critical. So before you take an ABG, one thing is very important. We are not computers to just analyze an ABG and tell you the what ABG interpretation. So before interpreting ABG, the most important thing will be the good clinical history. So why the patient has come to you in the emergency department. So anticipating possible underlying acid-base disorders. For example, if I know my patient is a COAD patient or a COPD patient, I know what to expect. I know patient will be in respiratory acidosis. So the underlying disorders becomes very, very important in these cases. So if a patient is diabetic, and he or she has been missing insulin, I know probably I will be thinking on the lines of diabetic ketoacidosis. So the underlying condition remains very, very important. Even for nursing, we should know that patient is a diabetic or a hypertensive or a COD or a renal patient or CKD patient will always be in a metabolic acidosis state. Also, pre-existing features like a circulatory shock or patient has come with a vomiting or a diarrhea or a GI losses, that becomes very, very important. Then medication history. All these drugs like a diuretic, a metformin, a SGLT2 inhibitors, all these diabetic drugs does cause changes in acid-base status. For example, a metformin leads to lactic metabolic acidosis. Then in toxicology, again, ingestion of drugs or toxins. So history taking is very, very important. So I want to emphasize it even more that history becomes very, very important before you take an ABG or interpret an ABG sample. So coming on the most important value, this we all know. So सबसे पहले what's most important, what we get to see is the pH. So what is pH? This is all theory. It is a negative logarithm of H plus ion concentration in the extracellular fluid. So negative means if pH decrease, H plus ion will increase. So if pH is more than 7.45, I told you the pH till 7.45 is normal. If pH is more than 7.45, that means patient will be in alkalemia or acidosis. And if pH is less than 7.35, patient will be in acidemia or alkalosis. So if you have just one value of 7.46 or 7.50, then this is in blood. So normally we call it as alkalemia. But if we take a whole picture, then we call it as alkalosis. If we also know the bicarbonate value and the PCO2 value, then the interpretation is different. So emia means blood. So pH of more than 7.45 is alkalemia. pH of less than 7.35 is acidemia. So how we calculate pH? This is theory again. It's very famous Henderson-Hasselbalch's equation. So it is pH is equal to 6.1 plus log of bicarbonate by 0.03 into PCO2. So this is how we normally calculate pH. Now, first and foremost thing that I want to start in ABG is about the oxygenation of the patient. So oxygenation is very, very important. We do see the metabolic status, but first important thing is the oxygenation in both adult and children. So if we see the normal PO2 value, a normal patient partial pressure of oxygen in blood is normally 80 to 100 millimeters mercury in room air. So if it is less than 80 millimeters of mercury, we call that patient is in hypoxemia. So if advancing age above 60, the PaO2 decreases by 1 millimeter mercury below 80. So in newborn, the range is around 40 to 70 millimeter of mercury. So anything less than 80 millimeter of mercury, we label it as hypoxemia. And with advancing age, it does increase by 1 millimeter of mercury beyond age of 60. So normally we keep the patients on ventilator. So what we set on ventilator is the FiO2. So we should have some kind of a relation between FiO2 and PaO2. So if my FiO2 is 100, then PaO2 normal should be 5 times. So it should be 500. So what I have mentioned is a predicted minimum PO2 is 5 times. So if 40% FiO2 is set, the ABG should, in normal cases, should be between 160 to 200 millimeters of mercury. So then is the very famous, again, second equation is the alveolar gas equation. Then this is basically the partial pressure of oxygen at atmospheric, at sea level. So it is 760 minus 47 into FiO2 minus PaCO2 by the respiratory quotient. So normal alveolar gas equation partial pressure is 97 to 105 millimeters of mercury. So the PO2 FiO2 ratio, I normally told it should be around 500. So 500 is normal. 400 to 500 we also consider it to be normal. So 300 to 500 is some kind of a oxygenation problem. And anything less than 300 or less than 200 is moderate to severe ARDS. So by basis of PF ratios, we can also tell that patient is in ARDS or not. So this is the importance of ABG in telling you the diagnosis also. For example, my patient's FiO2 is 40 and PaO2 is also 40. It means the value is 100. So it means that patient is in severe ARDS. So this is the normal looking ABG of the patient. So if you see the measured values, as I've told you, then there is something called as the corrected values. For example, temperature correction. If your patient is temperature is high, for example, hyperexia is there. So if the temperature is 38.6, you should mention the values because the values will change according to temperature. So at 38.6, the PaCO2, which was normal at 37, it has raised to 47.6. So this, you know that PaCO2 is now increased. So temperature correction becomes very, very important. And these are the calculated data. So not going much into detail, we also tend to see alveolar arterial difference, that is the AA gradient, that is normally 5 millimeters of mercury. But if it is more than 5 millimeters of mercury, then we say then there is some kind of a shunting is present. So not going into detail because it will not be required for nursing point of view. Then most important point is how you take an ABG sample. So normally they say that take the sample and analyze as quickly as possible. But what happens if there is delayed analysis? So if you've taken a sample and you've kept it and you're not analyzing, maybe your ABG machine is not there or you have to send sample somewhere else. So what will happen? So there will be consumption of oxygen and production of carbon dioxide that continues after blood is drawn. So normally we say that we should keep the sample on ice. So ice sample values are validated up to 1 to 2 hours. So we say that if you are not analyzing within 10-15 minutes or maximum 20 minutes, you should ice your sample and keep the temperature at 4 degrees Celsius, 4 to 6 degrees Celsius. But uniced samples becomes invalid within 20 minutes. That is very, very important. So as I told you, PaCO2 production keeps on going if you're not analyzing your sample. So this becomes very, very important. 3 to 10 millimeter increase of PaCO2 per hour does occur. So a value of 45, immediately after 1 hour of analysis, the value can rise up to 50. PaO2 values normally decreases and pH also decreases because the blood you have withdrawn, it will undergo anaerobic glycolysis that will produce lactates and it will lead to lactic acidosis. Then this is the temperature effect. So at normal temperature, 37 degree, change occurs every 10 minutes. So pH will decrease by 0.01, PCO2 increase by 1 millimeters mercury. But if the same sample, you ice that sample, the effects changes drastically. It slows down drastically. So it slows down by the value of 100. So you can see that pH at 10 minutes, the change will be just 0.001. And PCO2 1 mm at 37 at 4 degrees Celsius, it will be just 0.1 millimeters of mercury. So we should ice the sample as quickly as possible if we are not analyzing immediately. So air bubbles, we should avoid air bubbles at all times because partial pressure of oxygen is 150 millimeters of mercury. If we have air bubbles, they tend to diffuse very fast, and values of PaO2 will increase immediately because the diffusion is very, very fast. So, to avoid air bubbles, sample drawn very slowly and preferably in glass syringe. Normally, we do not do it in routine practice, but ideal scenario, it should be done in a glass syringe. So, what about heparin? How much heparin you should take while you are examining an ABG? So, the required amount of heparin is just flushing the heparin. That means you just have to cover the dead space. So it means just 0.5 ml of heparin is required per 1 ml of blood withdrawn. So if you take more heparin, there will be dilutional effects on results and decrease in bicarbonate as well as decrease in PaCO2 values. So syringe should be emptied by heparin after flushing, or only dead space volume is sufficient for dry heparin. Okay. So this is one very important aspect when we are withdrawing the sample. Just flush with heparin. You should not take it will not require more than 0.05 ml of heparin. And what is the site from where you take the ABGs? The most preferred site is the radial. And by chance, if you're not able to take the radial, you can take from femoral. But avoid the end arteries like a brachial or a carotid. You should not take sample from there. So best site will be radial. So the normal values we have seen, pH again 7.35 to 45, normal is 7.40, PCO2 35 to 45, bicarbonate 22 to 26, anion gap, as I told you, 12 plus minus 2, and albumin is 4. So all these values are very, very important when you are interpreting an ABG. So ABG is in respiratory acidosis or metabolic acidosis. The normal values you must know. So before we analyze an ABG, one very important step theoretically is you should check the validity of the report, whether it is valid or not. So pH of 7.3, PCO2 60, bicarbonate 30. So you have to check the validity. So as I told you, at a pH of 7.4, bicarbonate, the H plus ions are 40. If you increase the pH, the bicarbonate ions goes down. At a pH of 7.5, it will be 30. At a pH of 7.6, it will be 25. So this is how you calculate it. So at looking at this particular example, whether this is valid or not, so 24 into CO2, that is 60 by 30. So that comes to around 48. So pH is 7.3, the value is 48. If you see the table, it is 50. So it is almost equivalent. So this ABG would be a valid ABG. So this is the validity check we normally do in an ABG. Now coming on to the interpretation. So there are 7 habits of successful blood gas analysis. So this is very important when you are interpreting an ABG. So first thing, again, very, very important. Everybody must know, even the doctors, nursing staff, is to look at the 3 values. The most important value is pH. If you see the pH, then look at the bicarbonate and the PCO2 value. So first is pH. So if you can take home these 3 values along with the oxygenation, I think the purpose of this presentation will be done. So look at the pH first. If pH is less than 7.35, I have told you it will be acidemia or acidic patient. Patient is acidic. If pH is more than 7.45, patient is alkalemic. Now you have to see the second value, that is the PCO2 or the bicarbonate. Now, the most important thing is that I want to tell you is, if pH and PCO2 are moving in opposite direction, pH is decreasing, PCO2 is increasing. So the patient will be having a respiratory pathology. So pH कम हो रहा है, pH is less than 7.35, PCO2 40 से बढ़ रहा है, it is like 50. The pathology, primary pathology will be respiratory. And if pH and PCO2 are moving in the same direction, the primary pathology will obviously be metabolic. So first step is looking कि acidic है patient या alkalemic है या normal है. Then second step is looking primary pathology क्या. What is the primary pathology? So pH and PCO2 moving in opposite direction, primary pathology is respiratory. pH and PCO2 moving in the same direction, primary pathology will be metabolic. So second step. Second step is the metabolic or respiratory, as I've told you. Okay, if they are moving in opposite, then comes the third step. So third step is looking at the change. So if it is a respiratory pathology, whether it is acute or chronic. So these are certain set of formulas that nobody remembers, but definitely you should have jotted down somewhere to calculate at the time you want to interpret an ABG. So percentage change in pH is 0.08 into delta PCO2 by 10. So, and this is the expected pH. And if it is chronic, expected pH will be 0.03 into PCO2 by 10. So this is the expected pH change in chronic patients. Then coming on for a respiratory disorder. So once you have you know that patient is in respiratory disorder, because the third step is looking at whether the compensation, that is the renal compensation in this case, is adequate or it's not adequate. So whenever there is a respiratory issue, kidneys will try to compensate. Tendency of the body is to keep pH within the normal range. So there are certain buffers in the body that will try to keep pH between 7.35 to 7.45. Only when the buffers are not acting properly, the pH will be out of range. Till that time, the pH will be in range and body try to compensate for it as long as possible. So for a respiratory disorder, the compensation will be renal. So acute respiratory disorder, that is within 24 hours, the renal compensation will be slow. It will be one change in bicarbonate for every 10 change in PCO2. And for chronic, it will, for more than 24 hours, for one change in bicarbonate, there will be at least four times change in the PCO2 value. So PCO2 has to increase that much time. So respiratory alkalosis, 1 to 2 hours. So 1 to 2 hours, there will be change from 2 for delta PCO2 change of 10, the bicarbonate will change by 2. And for delta change of PCO2, again for 10, for respiratory alkalosis, the bicarbonate will change by 5. So this is slightly confusing. There is a mnemonic. Normally we keep it as 1, 4, 2, 5. So respiratory acidosis acute 1, chronic 4. Respiratory alkalosis acute 2, chronic 5. So as I've told you earlier also, so respiratory acidosis less than 24 hours, 1 change in bicarbonate for every 10 increase in PCO2, 4 change in bicarbonate for every 10 increase in PCO2 in respiratory alkalosis, 2 for respiratory alkalosis, and chronic 5 change in bicarbonate for every 10 change in PCO2. So next is if the disturbance is metabolic, then is the respiratory component adequate? So अगर metabolic है तो हम respiratory देखेंगे compensation, अगर respiratory है तो metabolic देखेंगे. So अगर metabolic है, if it is metabolic, then we apply a simple equation, that is a Winter's equation. So it's 1.5 into bicarbonate plus 8 plus minus 2. And for metabolic alkalosis, it is 0.7 into bicarbonate plus 21 plus minus 2. So this tells us about the primary pathology. I'm not going in detail of the secondary pathology because it is beyond the scope for certain for nursing point of view. But primary pathology, pH क्या है, प्राइमरली रेस्पिरेटरी डिसऑर्डर है कि नहीं है, अगर रेस्पिरेटरी है तो मेटाबॉलिक कंपनसेशन एडिक्वेट है, अगर रेस्पिरेटरी है तो मेटाबॉलिक कंपनसेशन एडिक्वेट है. सो दीज थिंग्स वी शुड नो. ओके, then last is the anion gap. Anion gap is very, very important. The simple formula is how to calculate sodium minus chloride plus bicarbonate. So as I've told you, normal anion gap is 12 plus minus 2. So if it is more than 12, we as a medicos have remembered it as mud pilers. This is the causes of an high anion gap would be mud pilers. It will be methanol, uremia. Patient could be in diabetic ketoacidosis, paraaldehyde, infections, ethylene glycol, and salicylates. So I've told you, very, very important for toxicology point of view, as also in septicemia and decay. So last step I'm not going to discuss because again it's beyond the scope. So this is how we normally interpret in ABG. So looking at an example of how to calculate an ABG. So look at the pH in the blood. This is the first step. Is the patient acidemic or alkalemic? For example, a 65-year-old male comes to us with CKD presenting with nausea, diarrhea, and acute respiratory distress. The ABG shows this value: pH of 7.23, PCO2 of 17, PaO2 of 235 on 50% of venturi mass. The other values are sodium 123, chloride 97, bicarbonate of 7, 1, blood urea nitrogen 119, and creat of 5.1. So क्या देखेंगे? What is the first thing we see? First thing, first step 1 will remain, is the patient in acidemia or alkalemia? So pH of 7.23, patient is in acidemia. So PCO2 or bicarbonate or PCO2 are in the same direction or opposite? Bicarbonate भी कम हो रहा है, bicarbonate is 7, pH भी कम हो रही है 7.23, so in same direction. So it would probably be metabolic cause. So patient will be in metabolic acidosis. So the primary disorder, pH PCO2 opposite direction respiratory, pH PCO2 same direction metabolic. Then metabolic hai, metabolic changes conditions are suggested if pH changes in the same direction and respiratory pH changes in the opposite direction. So pH is low, PCO2 is low, pH and PCO2 are going in the same direction. So primary pathology is metabolic. So for metabolic we applies Winter's formula. इसमें Winter's formula लगाएंगे, formulas की values देखेंगे कि compensation adequate है कि नहीं. So if metabolic acidosis, as I've told you, values are 1.5 into bicarbonate plus 8 plus minus 2. Once we apply this formula, then we come to know whether it is appropriate or not. So if we apply it, it will be coming as appropriate compensation based on the Winter's formula. So the correct compensation will always be there if it is a primary metabolic disorder. अगर यही चीज respiratory होती, as I've told you, how it changes, this changes like this. 1, 4, 2, 5. रेस्पिरेटरी एसिडोसिस है, एक्यूट है 1 बाइकार्बोनेट बदलेगा, क्रॉनिक है 4 से बदलेगा, रेस्पिरेटरी एल्कोलोसिस एक्यूट 2 से बाइकार्बोनेट बदलेगा एंड क्रॉनिक है 5 से बदलेगा फॉर एवरी 10 राइज इन PCO2 वैल्यू. Slightly confusing, but this is how you have to mug up certain formulas actually while you're interpreting the ABGs. So last is the anion gap. It is basically the difference between the cations and the anions. The most important cation, as I've told you, is sodium, and the anions is the sum of chloride and bicarbonate. So normal is plus 12 plus minus 2. So this is the calculation. Sodium minus bicarbonate plus chloride. So normal values is 12 plus minus 2. So normal should pata ho. An ion gap normal is 12 plus minus 2. In most of the ABGs now, they do mention the values of an ion gap in the ABG itself. So you should know the normal ke ye zyada to nahi hai. At least you can tell your doctor that probably it is a high ion gap metabolic acidosis. Agar wo value zyada aa rahi hai to. So doctor will be on high alert. So certain key things I think you should know. For example, a pH, the oxygenation status, PaO2, the ion gap, these 4-5 values in the entire set, you should know what are the normal values, and if you know normal, then only you can tell about the abnormal. So corrected ion gap, I'm not going into detail. So this is the ion gap of the patient, and high ion gap metabolic acidosis, the differentials I've already told you, the mud pilers. Then comes the metabolic alkalosis, pH of more than 7.345. Normally it happens in GI losses, vomiting, patient diarrhea साथ आ रहा है, vomiting, GI losses, or over diuretic prescribed किया हुआ है, if any doctors have prescribed, then you will find patient is in metabolic alkalosis. So just giving fluids in this case will treat the patients. So this is the importance of just knowing the ABG and interpreting the ABG, and also the history. If history is clear cut, मेरे पेशेंट को पिछले 2-3 दिन से बहुत डायरिया है, बहुत वॉमिटिंग हो रही है, and he is on diuretic also, you know patient will be volume depleted, and patient's ABG will tell you about the metabolic acidosis status. So there is something called as saline responsive, and then the saline resistant. If urinary chloride is less than 25, it is saline responsive. It is more than 25, it is saline resistance. Then the respiratory alkalosis last. Normal causes, कोई डरा हुआ बच्चा आ जाए, पेपर है जी कल, so that patient might be having anxiety, might then patient are normally hyperventilating. So these patients are in respiratory alkalosis. Pain, fever are very important things. Then drug overdose, CNS, pregnancy, sepsis initially presents as respiratory alkalosis only. So this is all about ABG, what you should know. Now I will try to I will try to discuss certain examples that are very basic examples of ABGs. So primary disorders are I'm only going to discuss. So this is the case again. History is very important. I have just mentioned the values. You should ask for history. So case one, the pH in ABG is 7.27. Then PaO2 is 60 on 5 liters. Bicarbonate is 26, and PaCO2 is 58. And an ion gap is 12. Albumin is 4. So what is the primary disorder? So again, first step, पहला स्टेप है पीएच देखो 7.35 से ऊपर है या नीचे है. इट्स लेस देन 7.35, इट्स 7.27. PCO2 58, नॉर्मल वैल्यू है 30 to 40, so it is increased. 40 से ऊपर it is 58. So pH and PCO2 are moving in opposite direction. It means the disorder is respiratory. So first thing is pH acidemia, then CO2 is more. So moving in opposite direction, it is a respiratory disorder. Then you look for the compensation. So compensation के लिए वही है, अगर chronic है कि acute है. अगर acute है 0.008 into आप पीस वैल्यू करोगे डेल्टा चेंज इन PCO2, डेल्टा चेंज कितना हुआ 58 minus 40, that is 18. So it will be 18, multiply करोगे the value of pH in acute will be 7.26. So this seems to be a acute problem. Okay, just looking at the formulas. So this is the change. So this is the case of respiratory acidosis. Then case 2, pH 7.54, PCO2 24, then bicarbonates of 20. pH कहाँ जा रही है 7.45 से ऊपर है, primarily alkalemia. Then PCO2 bicarb वो देख रहे हो आप, PCO2 वैल्यू 30 to 40 होनी चाहिए normally. So it is less than that. No, so it would be 24. So the disorder again respirate moving in opposite direction. pH बढ़ रही है, PCO2 कम हो रही है, moving in opposite direction. Primary pathology is respiratory alkalosis. Then you see कि it is just respiratory or not. Again applying the same formulas. So value again it is acute respiratory alkalosis. So this is the case of acute respiratory alkalosis. Then coming to the case 3, pH of 7.58, PCO2 bicarbonate 46, then again PCO2 of 55, PO2 of 80. So again pH more than 7.4, 7.4. So this, they are moving in the same direction. The primary disorder is PCO2 भी बढ़ा हुआ है, CO2 40 से ऊपर है, pH भी बढ़ा हुआ है. So the primary disorder is metabolic alkalosis. So this is the case of metabolic alkalosis. Probably diuretic induced hoga. Yeah, it could be because of vomiting or diarrhea, as I have told you. So again, applying for the compensation. So compensation apply karoge, aage you will come to know that this is a normal plain metabolic alkalosis. Then you see whether it is chloride responsive, saline responsive, or saline non-responsive. Urine looking at the urinary chloride. So differential is metabolic alkalosis. Last, case 4, pH 7.46, bicarbonate 16, then PCO2 80, 20, PO2 of 80. So again, pH is more than 7.4 and PCO2 is less than 40. So again, it is a case of both moving in opposite direction. It is a respiratory alkalosis. Just applying the formulas, you get to know about these values. So it is now, if you apply the exact formulas, it is basically chronic respiratory alkalosis. So just to touch these main 4 things: metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. So that's why I've taken these examples. I've not gone into detail of the compensation, whether it is adequate or not, all the delta and ion gap. So these are certain basic things that we should know in an ABG. So that's all I want to tell actually about this ABG. Thank you for your kind attention. Thank you. I do have certain MCQs if you want me to discuss right now. Dr. Nitin, anything from your side? Mhm. I am audible?
Yes, sir. Sir,
Yeah.
please ask
Doctor.
them to write any, if they have any question, please write in the chat box.
Yeah, I see. Should I discuss MCQs or no? Any questions?
Am I audible?
Yeah.
Yeah. Any questions from the audience? No questions on such a complex topic.
Yeah, there's somebody has written about the MCQ. It's slightly complex actually. I try to cover just the basics, but I know it's slightly confusing. But yes, certain values we must know. Four or five values, I think we all should know so that we should know where we are heading. What is the pathology like?
Absolutely. So, Dr. Harsimran, you follow these calculations of metabolic acidosis every time you come across a patient in your clinical practice?
See, normally every time we don't, because with experience now we tend to know whether it is purely metabolic disorder or it is a metabolic plus respiratory. But if we are stuck up, if we are not knowing the diagnosis, then we do calculate. And I asked every resident to calculate also. So during when I was doing my FNB critical care, I was asked to keep a slip of ABG of all the formulas in my purse all the time. And I was asked to solve every ABG on the backside of that paper with
Yes,
interpretation till third disorder. So for nursing point of view, primarily disorder probably will be most important, knowing the normal values. So
absolutely.
calculation for every ABG is not possible. With practice, you tend to know what you're dealing with. But if you're stuck up with the diagnosis, yes, we tend to calculate the ABGs.
Yeah, I think the real purpose of ABG is actually to arrive at a diagnosis. When we do
Yes,
it in clinical practice, we just say metabolic acidosis or a respiratory acidosis, and we may just adjust our ventilatory setting or decide fluid. But I will say the real value lies if you are able to conclude a diagnosis. High anion gap metabolic acidosis, you narrow you find the differentials, you narrow to a diagnosis. That's how the ABG works out.
true, sir, true. So to aid the diagnosis, very, very important. And as I sir, discussed also, history taking becomes very, very important. Just interpreting ABG without proper history again carries little significance.
Yeah, absolutely. Okay, I think if there is no other question from the audience, we conclude the session. Yeah, somebody is I think asking a question. Yes,
Yeah, they have
yes.
written about the MCQs actually.
Okay,
Let me see if I can share my MCQs. Yeah,
okay.
I have made six MCQs again. So yeah, these are the MCQs. Yeah, is my screen visible?
Yes, yes, yes.
Okay. So first is if pH and PCO2 moves in opposite direction, then primary disorder is. This I have told I think multiple times, maybe 5, 7 times in my presentation. So pH PCO2 moving in opposite direction, the answer is B, respiratory. Then second, yeah. Second most preferred site to take ABG sample is A, brachial, B, carotid, C, radial, D, dorsalis pedis. So most preferred site is answer
See,
is C, radial. The normal value of an ion gap is A 18, B 20, C 12, D 8. Normal value of an ion gap. So answer is again C 12. So it is 12 plus minus 2. Fourth, how much amount of heparin is required in the syringe before taking ABG sample? Options A 0.5 ml, B 0.2 ml, C just flushing the syringe with heparin is all that is required. D heparin is not at all required. Answer would be C, flushing the syringe with heparin. So just covering the dead space. So it will be around 0.05 ml. So just flushing the syringe with heparin is more than adequate. Fifth question, normal PaO2 value in young adult male is hypoxemia देखना हमने. So what is the normal value? एक adult normal male का देखा, so what is the PaO2 value that you will see in ABG? Options A, 60 to 80 millimeter mercury, B, 80 to 100 millimeter mercury, C, 40 to 60 millimeter mercury, D, 20 to 40 millimeter mercury. So we have discussed this again. It is 5 times the normal. अगर मैं normal breathe कर रहा हूँ 21% पे, so it will be into 5. So that will be something between 80 to 100 millimeters of mercury. Yeah. So last question for the day. Very easy question. Just अगर ये नहीं answer कर पाए, then probably my purpose of presentation is not solved. So normal value of pH. Normal value of pH we should all know. Options 7.35 to 45, B 7.30 to 40, C 7.45 to 7.55, D 7.28 to 7.32. I think most looking at this will answer it. Answer is A 7.35 to 45. Yeah, that's all from the MCQs that I wanted to ask this. So very basic I have kept. So most of the time I've answered it correctly actually.
Yes. Yeah. Any other questions? Any other questions? I think you can raise your hand. Okay, I think nothing in the chat box as well. Okay,
Either they have
Dr.
understood everything or they have not understood anything.
I think
So I hope the first one is there.
the important thing is that they implement these things in the daily practice.
Yeah, true.
So thank